get a little bit into managing the disease. We talked about a little bit about how exactly what diabetes looks like, what predisposes one to diabetes, what it means to be pre-diabetic. But if you're a person with diabetes, exactly how do you manage it? And insulin is one of the major things that we talk about when we have this conversation. I know there's so many conversations around the cost of it, the cost of healthcare in general. But exactly what role does insulin play now when it's not your body, not the pancreas, like you said, in managing diabetes, Dr. Rilwan?
Well, okay. First of all, when it comes to the discussion around insulin, I think in and out of the consultation room, it's one of it's a difficult one, especially in the consultation room, when you talk about initiating the insulin. So when you bring up this conversation, it's usually not an easy one to discuss, because using insulin is life-changing, because insulin on its own as a medication for managing diabetes has its own side effects in terms of causing low blood sugar, and this is one of the biggest fear of patients, having low blood sugar, which can eventually lead to hypoglycemia, coma, and death. So managing it, you have to be really quite accurate in how you do it. And essentially the use of the insulin is done by the patient at home. It's not one they come to the hospital and we inject. There are different types of insulin. I think you mentioned the cost. The cost is something probably a discussion for another day. But there are different types of insulin. There's some you inject once a day. There's some you inject twice a day. There's some 3 times. There's some 4 times. So depending on the patient care, it's different. And for patients with type 1 diabetes, it's actually, you have to inject up to ideally 4 times a day. And for this reason, I think the how to inject, the change in the lifestyle, I think suffice to say that diabetes is still associated with a lot of stigma. Patients, people living with diabetes don't want other people to know that they have diabetes, and injecting means that people will have to see that you're injecting, and injection of insulin also comes with a lot of monitoring of your sugars, because you have to know what your sugar level is for you to take it, and after taking it you have to know how your sugar level has come down. So it involves multiple monitoring as well, and as you know, the monitoring also in our setup especially involves a bit of pricking to get to check your blood sugar level. So there's a lot of myths around diabetes, around insulin therapy, because a lot of, and we get these questions and we let the patients tell us more what their fears are, why they don't want to use. And when you clear this out, I think the journey becomes easy, because you tend to talk to them and they understand why you're doing this and how it's good for them. Because ultimately, by the time we decide to initiate insulin, it's actually good for them. I want to mention that type 1, obviously, we said from the outset, there is initiation of insulin.
Yes.
But even for some type 2, from the outset, we tend to start with insulin. So because we get a lot of these questions about, is my diabetes end stage now? Because now I'm going into insulin. And we say there's nothing like end-stage diabetes, because some people require insulin at the beginning, some somewhere along the journey of the living with the condition. Yeah. So I think the issue with insulin is it's a good drug. It's helping patients and it's preventing complications. It's just what I emphasize is patient self-management, and with that we do a lot of education for the patient to learn why we are using it, how we are using it, what they need to do in case what happens, explain to them the symptoms of hypoglycemia, how to correct the hypoglycemia in case it happens. So when you do that, they get the confidence to actually take care of it themselves.
I like that. And I'm sure that applies for their caregivers as well. But I'll go very briefly to Dr. Shilpa and we'll carry on the conversation a bit later. But some of the complications that come with diabetes perhaps involve the feet, and at the Foot and Wound Clinic, I know you deal with a lot of those. What are the complications that comes with this diabetes, especially if left unchecked for a long time?
Okay, so one of the main complications that happen with diabetes is what we call neuropathy or nerve damage. Nerves are like the telecom lines or the telephone lines in a country. If your telephone lines are down, it becomes difficult for your brain to communicate with your foot. you may step on a Lego piece or even something sharper, and it's supposed to
Hurt.
it's supposed to hurt. Pain is good. You're supposed to take off your foot from what's harming it. In persons living with long-standing diabetes or uncontrolled diabetes, they do not have the sensation. Therefore, they may get injured, and they do not realize that they have a festering wound for a long time. One. Second thing is, with lifestyle comes smoking sometimes, and even if the person is not smoking, with diabetes comes what we call vasculopathies, or a reduction in the blood supply to the feet. So these two, plus changes in architecture in the feet, because again, the neuropathy tends to give rise to abnormal pressure points and areas in the feet, and bony architectural changes that predispose to wounds. And thickening of the skin dies, there's an ulcer inside, but a person cannot see it on the outside. So that's where the foot comes in.
Well,